and welcome to another podcast. Today we're going to talk about drowning management. Now there's often some debate around whether or not drowning is still an important thing to discuss and research and really keep in the forefront of your mind, especially when working in the sort of environments we do. The reason I've decided to do a lesson on drowning is, in case you haven't been keeping track of what's happening around the world, there's an increased probability that a lot of our work is going to involve water and shorelines. Without going into too much detail, it's becoming a very, very popular topic across many organisations. And today, drowning still represents a significant risk for certain demographics. Now, they're being the very young, the very old, but it's also the leading cause of death in young men. And we just so happen to work with a lot of young men. So I think it's important for us to have an understanding of what drowning is, the different types of complications and considerations that come from drowning victims and drowning patients, and also the management in the sense of what we can do and what we should do in the environments that we find ourselves. So we'll just start with looking at a few classifications and a bit of history on drowning, if you will. So drowning today is defined as the process resulting in primary respiratory impairment from submersion or immersion in a liquid medium. Okay, so that's a very open, broad context. But back in the day, it used to be classified as wet, dry, near drowning, silent drowning, active drowning, passive drowning, and they're no longer accepted terms. And in reality, they haven't been accepted terms since 2002, when the World Congress of Drowning, held in Amsterdam, basically came up and redefined what drowning is. So if you hear these terms being used, which you will, they're usually used just to describe the events that led up to a patient's condition. But in reality, drowning is the definition I just gave, and you can have further classifications in morbidity or non-morbidity, or fatality and non-fatality. And that just helps us fine-tune what sort of management we're going to do. Now, in the event that somebody's in the water and in great distress, but they don't actually have any respiratory impairment, then that should just be considered a rescue until symptoms present themselves, whereas in the past it used to be considered and treated as drowning, but there's not a lot of evidence to support that unless there's some evidence of inhalation or ingestion of the water itself. Having a closer look at the epidemiology, when we're dealing with adults, because there's a lot of papers and a lot of references associated with children, obviously they're the highest risk of drowning. So focusing just on adults, the drowning often involves overconfidence, injury before they get drowning, and alcohol itself. On average, there's 372,000 deaths per year as a result of drowning, and it represents 7% of all injured related fatalities across the globe. Okay, so it's quite a significant number when you think about all the ways you can die from an injury, and drowning constitutes 7% of that. In Australia, we are lucky and unlucky, depending how you look at it, of having a lot of water around us. We're an island, we're surrounded by water, and there's things in the water that can make it quite difficult to swim and can paralyze. So it's always going to be a leading statistic when you look in Australia, which means it should continue to be a consideration for clinicians. Now, they're the numbers of deaths associated with drowning, but for every one of those deaths, there's approximately 4 people that fit in the category of that non-morbidity that will need treatment. So about 1.5 million per year. And of that 1.5 million, 50% of them will need hospital admission and interventions. Okay, so all of them need some sort of monitoring, but 50% of them will actually require ongoing management. So when we look at the classifications of the non-fatal or the non-morbidity drowning, we need to be aware that it's not just the people that ingest or inhale the actual liquid when they're in the water. So it's not the people that are under the water and they breathe in a lungful of water that we're talking about. Sometimes, especially when we're dealing with the ocean, it can be associated with sea spray. Now, when you have a high amount of sea spray, it can bring on asthma-like symptoms, and it can bring on respiratory impairment just from the sodium and the sea itself. So prolonged exposure to sea spray can in fact bring on a type of drowning, but it's more likely an irritation that it really causes an asthma-like symptoms. When they get in the water and they start panicking, then they're more likely to inhale larger droplets of water, which results in drowning itself. And when we have a closer look at the pathophysiology, so we actually have a good look at drowning and the characteristics surrounding it, there's a lot of literature, and sometimes it's hard to define and really pinpoint down what's going on. So I'll do my best to explain some characteristics around typical drowning, just knowing that there can be certain left and rights of what I'm describing that can also result in similar pathophysiology. So during the drowning process, an individual instinctively holds their breath. They do this consciously until there's an internal boost to inspire. As a result, they inhale water. Okay, so all of a sudden they cannot hold their breath any longer, and the reflex will make them inhale wherever they are. If they're under the water or partially under the water, then they're going to inhale fluid. Now that fluid reaches the airway and stimulates a cough reflex and a laryngospasm. At this point, when the water gets into the lungs, it causes surfactant loss, leading to consumption of alveoli capillary membranes with pulmonary edema as a result of the increased permeability that occurs within the membrane. Now, pulmonary edema obviously impairs gas exchange in the lungs, which results in hypercapnia, and then you get your acidosis and obviously hypoxemia. The progressive reduction in the arterial partial pressure of oxygen interrupts the laryngospasm, and then an additional amount of water is inhaled. Now, if that person is not rescued, aspiration of the water continues, and hypoxia leads to cerebral hypoxia, which rapidly causes loss of consciousness and apnea. Hypoxia mixed with acidosis can also contribute to the cardiac dysfunctions with a high risk of dysrhythmias, which usually is characterized by either tachycardia, bradycardia, can have pulseless electrical activity, or asystole. Okay, so two different methodologies occur, resulting from initial laryngospasm, which fails, for lack of a better term, or a violent case of inhalation, which doesn't cause laryngospasms, either way resulting in aspiration of water itself. Now, in regards to what water, there's a lot of debate and a lot of discussion that has been around that particular question. Now, the determination of toxicity of the water that the victim was immersed in, meaning fresh water or salt water, realistically has little importance in non-fatal drownings. When you're dealing with ones that result in loss of consciousness, then obviously you're dealing with the fresh water causing a hyperosmolar water link compared to the salt water, which causes a hyperosmolar water draw of the plasma. Okay, so two different types. Either way, there's fluid in the lungs. It's just got to do with electrolytes. Now, the only reason electrolytes become a thing to think about is when that volume and the serum of electrolyte changes with a significant volume of fluid aspiration. So meaning if they are in that fatal category, meaning they have a lung full of fluids, and either one causes different amounts of electrolyte displacement, as that fluid is aspirated, the body's electrolytes are aspirated with it. So in actual fact, it is more important to note if the fluid was contaminated. so sewage water, because that water will actually mean something for both fatal and non-fatal patients, because the contaminated water can lead, and highly probably will lead, to a respiratory infection. Therefore, prophylactic antibiotics are recommended. Another consideration to think about when you're dealing with water is how cold that water is. So cold receptors include that gasping, hyperventilation, and increased cardiac output, coupled with peripheral vasoconstriction and hypertension. These responses can increase the metabolic rate, which in turn decreases the ability to hold your breath. So generally speaking, someone can comfortably hold their breath for about 60 to 90 seconds in comfortable air temperature water, or even now in a room without the water. You can hold your breath for 60 to 90 seconds. Now this can reduce down to just a few seconds when you're in water that is colder than 15 degrees Celsius. Now 15 degrees Celsius may not seem cold, especially when you're dealing with the atmosphere. When you're dealing with water, remember you lose heat 30 times faster in water than you do in the atmosphere. Okay, if you want to test this yourself, just jump in cold water or take an ice bath and take note of how rapidly you're breathing and try to hold your breath. Okay, it's very, very difficult to do. So that's part of the dangers associated with cold water, as well as the inability to actually get out of the water due to exhaustion. But on the other hand, if a person is submerged in cold water, that hypothermia can provide a protective mechanism. Often does when dealing with children, because the hypothermia also reduces the consumption of oxygen in the brain and delays cellular anoxia and ATP depletion. Okay, so it can be a good thing, but don't rely on it. If someone is in freezing cold water, don't leave them in that freezing cold water thinking that it's going to be the best management. Speaking of management, let's have a look at what we should do when we're dealing with these drowning patients. So as a general rule, general overview, you want to get them out of the water as soon as possible, but as safely as possible. There's a lot of considerations when you're dealing with water rescues, and one of the first considerations is your ability to actually help that person. If you can't help that person, then that's reality. If you do not have the means to rescue that person, you do not have the equipment, the strength, the swimming ability, the knowledge, whatever the variable is, if you don't possess it, then that's reality. It's a hard reality, but that's it. Everyone else would rather deal with one casualty than two. So always remember, even though it's part of our personality to almost sacrifice our well-being for others, you really need to consider it when dealing with water, to the extent that everybody in the profession of lifeguarding recommends that jumping into the water is the last thing you do, and you only do it if you have certain variables in place that means you're going to be able to get them out. Okay, so if you don't have a flotation device with you, then it's a really, really big call. Okay, once you're in the water and you've got to get them out, you have to consider certain complications that can occur from the water. So people can get spinal injuries associated with water incidences and water accidents, but it's not as prevalent as people think. It's only about 0.5% of the case. And these spinal injuries can result in spinal shock, so temporary neurogenic loss, or it can actually result in neurogenic shock, which arguably is the worst type of shock. Okay, you get profound vasodilation, you have the inability to regulate your respirates, you get bradycardia, so if all the mechanisms that are supposed to kick in during shock can't. And to couple that, you're in freezing cold water and you're losing a lot of heat because of the vasodilatory response. So it almost compounds it. So Worst case scenario is that. What's very common is people ingesting water. Okay, very, very, very common, which we'll discuss later with airway management. Okay, so all these things can be at play, which is why we want to get them out of the water, because you want to reduce those complications. When you're in the water, if the person is unconscious or semi-conscious in the water, it's actually really important for you to keep their head and body at the same level. Now, this is for a couple of reasons. The first one is the high probability associated with water in the lungs or in the stomach in particular, which if you put them head down can result in aspiration or further aspiration in this case. And then in the case the person is hypothermic or at worst has neurogenic shock and you put them feet down, then that vasodilatory response is going to move the blood away from all their vital organs. Okay, so it's very important that you keep them flat, because you can also have associated dysrhythmias from moving them too much in a hypothermic state. So for rescue and for everything, even with treatment, you want to keep them supine. The only time you actually roll them over is when they're coughing up, aspirating, and you sort of have to clear their airway initially, because you don't have suction or something like that. When they're out or when they're in the water, you need to assess level of consciousness and their ABCs. In the event that someone is not breathing in the water, I don't care how good you think you are or how small the patient is, you cannot do CPR in the water. You can, if you're trained and quite good, you can do rescue breaths in the water, okay, but realistically, if that's going to delay you getting them out of the water, then don't bother. Once we get them out of the water and we start to ascertain what side of the fence they're sitting on, either the morbidity side or non-morbidity side, which basically denotes whether or not they need CPR or they don't. And obviously the management will change associated with which side of the fence they sit on. If someone's on the morbidity side, you need to start BLS as soon as possible. Okay, even if you don't have a defib there, even if you don't have equipment, you need to start compressions, CPR straight away. Now, in regards to ventilations, rescue breaths, that sort of thing, rescue breathing and EAR is only really quantified when associated with drowning victims. To the extent when they changed the ratios associated with CPR and they removed rescue breaths from the equation, as in, for those that aren't old enough, we used to start CPR with breaths instead of with compressions. Okay, that used to be the regime. And whenever you were dealing with drowning victims, you do 5 rescue breaths instead of 2. And there was so much debate associated with whether or not those rescue breaths should be kept because of drowning. So drowning is the only variable out there where rescue breaths play a full role. Now, what that means for you is if you have a drowning patient, a patient that's been in the water, submerged, you've taken them out, compressions only is not the best treatment for these people, especially when you're dealing with children. We need to get good amounts of pressure into their lungs to help clear that water. Now, practically speaking, using a BVM, IPPV, can be difficult with these patients when using rescue breaths, because you actually can need quite a lot more force than the BVM can actually generate on the first couple of breaths because of the water that is in the lungs. Okay, so if you have a pocket mask where you can get a good seal and get a good controlled breath in, sometimes that can be better. But be prepared that as you breathe in, a whole bunch of water can come out. And as you start doing compressions, a bunch of that water's going to come out as well. That's why we don't encourage Heimlich maneuvers or postural draining or anything like that, is because compressions is going to clear a lot of that fluid. And if you put an OPA in or an adjunct, then what you're actually doing is you're creating a space in which that water can actually shoot out. And you'll see the water will actually shoot out the end of the OPA like a spout. In some cases, not all cases, depending on how much they're ingested and how long they've been in the water. So just be aware of that. As you're doing BLS, you move to ALS as you can. Once you get the drugs, once you get all these things, you move into ALS. Because the person's probably hypothermic, because it's associated with water, you need to test that. You need to see if they're hypothermic, and if they are, you need to apply the rules of double spacing the drugs, prolonged CPR for hypothermia management. So just remember the rules associated with hypothermia when doing ALS. Eye gels are a great idea, but you don't want to put them in day one. Remember, BLS straight away and then moving in because of those reasons we spoke about. You want to clear as much of the water out without any obstructions with good compressions and rescue breaths, and then you can put an eye gel in. Once you get an eye gel in, a nasogastric tube is essential. Ingesting water in drowning victims is highly probable. When you're dealing with the non-morbidity side, you're dealing with 65% of patients will ingest water. When you're dealing with the morbidity side, which we're talking about now, it's up to 89%, which means as you're pumping away and as you're giving breaths, and if you don't quite do it right, aspiration is highly probable from regurgitation. So you want to have that nasogastric in the end of the eye gel in order to clear that water away from the stomach as it comes up. Now, whilst the eye gel is really good at protecting the airway, it's not a guarantee, especially when you're dealing with pressures. So you want to have that ability to clear it out. Now, in the event you obtain ROSC, the person comes back, they have return of spontaneous circulation, they can breathe by themselves, evacuation is a must. And you almost manage in the same way as if you would for the non-morbidity patient, but with a much, much higher priority. These people cannot hang around. There's no Hollywood here where you bring someone back from the death of drowning and all of a sudden they continue for the next 6 days hanging out with everybody. That doesn't happen. You've got to get rid of them. They're going to have a rough road to recovery. If someone's on the other side, the non-morbidity side, they can still be unconscious. But if they don't need CPR, then they're classified as the non-morbidity. If they're unconscious but they're still breathing, then you can place them on their side with the head tilt because of that associated risk of regurgitation leading to aspiration. You want to help them drain it out in the event they vomit. You want to help it clear. You don't want them to move into the morbidity side. From there, vital signs are essential. BGLs, see if that was the cause or the associated hypothermia has caused the BGL to drop. You want to do cardiac monitoring, definitely, because of the electrolyte shifting and the risks associated with dysrhythmias. And oxygen can be needed. And oxygen can be quite difficult because it's sometimes you need oxygen delivered by CPAP or non-invasive ventilations. Now, if you don't carry it, you don't have the skill set to do that, then that just means that you need to get them out of the area, because sometimes putting just normal pressure of oxygen in doesn't actually help the patient. They need that increased PEEP or increased pressure in the base of the lungs in order to help clear the fluid that's in there and prevent the fluid from getting worse as well. So the general rule of thumb is we only give oxygen in drowning cases if it's less than 95 with that respiratory compromise. So they actually have a problem with breathing and it's less than 95. Then we give oxygen to try to keep it above just 95%. We're going to manage hypothermia. So removing the wet clothes. Remember the 30 rule, 30 times faster loss of heat if you're wet. So removing wet clothes, wrapping them in something even if you don't have clothes is better. Wrapping them in just a space blanket is pointless, is ridiculous. Don't do it. Space blankets do not work without a layer of insulation. You must have something in between the body and the space blanket. From there, remember, evacuation is the priority. But if you have them for a little while longer and if you're in a facility that can do a little bit more, then you do a little bit more. Let's say you're working in a facility and somebody from external has brought this patient to you after they've had that non-morbidity drowning. Okay, then you can do more. Intravenous cannulation and therapies can be great, especially when you're dealing with a shock state from hypothermia or spinal shock, anything like that. Warm fluids in hypothermia is obviously the best way to go if you can do it. Antibiotics, as we discussed, based on whether or not the water was contaminated. If you're dealing with floodplains and things like that, this can be a massive increased risk of contaminated water. So then prophylactic antibiotics for all patients, either side of drowning spectrum, will be given prophylactic antibiotics. If somebody is unconscious or profoundly hypothermic, then considering the use of IDCs and NGTs can be a great idea, because you can actually do warm saline lavages in these areas to help increase the body temperature. Now, obviously, this will only be done on MO's orders, but it is a management for hypothermia. So if you get these tubes in someone earlier, it can just save a lot of time. Depending on what facility you're in, you need to consider evacuating them to a facility that can monitor them or / care for them for a long duration. Okay, if you are in that facility, then every patient who's associated with drowning, or what they used to call near drowning, so they had a water rescue, they had some sort of respiratory compromise, even if they initially appear perfectly fine, they can still deteriorate with delayed pulmonary edema up to 4 to 8 hours later. Okay, sometimes even longer, but you'll start to see signs within the 4 to 8 hour mark. So everybody in that state needs to be observed and monitored for 4 to 8 hours before they're allowed to be released. Meaning, if they're in a field environment and you're a solo clinician, you can't really afford to monitor them for this point of time, and you have the ability to get rid of them, then you should. For the monitoring, if they end up being fine, they can return. Obviously, play it by ear depending on where you are and what you're doing, but that is the recommendation for all patients that's been submerged or immersed with any type of respiratory compromise in a liquid medium. Okay, that brings us to the end of drowning management. As you can see, a lot of little considerations to think about. Some of the hardest aspects of dealing with somebody who has drowned is juggling the patient's condition with your priorities and what you are going to do as the solo clinician. Because obviously during BLS, we want to make it easy for ourselves and we want to get a supraglottic airway in, because then CPR and ventilations is much easier. In the event that someone's drowning, your main priority is actually those rescue breaths and initial compressions in BLS as quickly as you can in order to clear most of that water, especially from the dead space of ventilation. This will allow ventilations to be much easier, and with the increase in pressure from the ventilation with a closed loop supraglottic airway after the fact, will help shift the fluid out of the lungs. Remember to put the nasogastric tube in the back of the eye gel in order to protect the airway from potential and highly probable aspirations. Hypothermia is a high probability with drowning victims, either morbidity or non-morbidity side. Neurogenic shock and spinal problems is a consideration, but it only constitutes 0.5% of casualties. So, good old rule for spinal: if they're conscious and able to control their own space, head and space, then you let them do so. If they're unconscious, you manage them gently and appropriately, but putting them in a hard collar when you're trying to resuscitate them is not a good idea. It interferes with airway management, it interferes with getting water out of their lungs. Okay, so you really only need spinal precautions when you're moving the patient, if you consider spinal to be one of the variables that you're dealing with. Another role you can play in the diving space is obviously being an advocate for safe play. Even if you are a strong, powerful swimmer, never think that you're invincible around the water, and never mix alcohol and unsafe play when around the water. And if you see mates doing it as well, have the courage to pull them up Let them know that drinking and swimming is never a good idea. And if they are dealing with motorboats or anything like that, then life jackets really should be worn. But until next time, take care.